Qul huwallahu ahad, Allahu samad, lam yalid, walam yulad, walam yakun lahu kufuwan ahad. In the name of Allah, the most gracious, the most merciful, say, He is Allah, the one and only, Allah, the eternal, the absolute. He begotten not, nor is He begotten, and there is none like unto Him. Welcome, everybody. This is another one of those wonderful teaching programs that has been hosted by AMWPA, which is a nonprofit organization that was founded in 2008, consisting of a group of women, Muslim physicians and dentists, and allied health promotion for preventative and health education in the community. The vision is to promote health, welfare, and education of women, and subsequently the communities and the members. And we've been very active during the pandemic in educating the community and providing masks throughout the Metroplex. We also provided meals for frontline workers and offered merit programs to Muslim female students in medicine.
Assalamu alaikum wa rahmatullahi wa barakatuhu.
I am delighted today to introduce one of my alumni from Dow Medical College as we talk about understanding arthritis, which is truly not understood by our community members, but is incredibly common in our community and throughout the world. I am very pleased to introduce Dr. Sana MAKHDUMI, who graduated from Dow Medical College in Pakistan. She did her internal medicine residency and was a chief resident at the University of Alabama. She did then her rheumatology fellowship at Emory University in Atlanta, Georgia. She was the chief fellow and the recipient of Fellows in Training Award. Subsequently, she trained other medical students and rheumatology fellows as a clinical assistant professor. Currently, she is practicing at Baylor Scott & White in McKinney and is accepting new patients. I'm delighted to welcome Dr. Sana MAKHDUMI. Take it up from there.
Thank you so much, Dr. Zahabi, for wonderful introduction. Assalamu alaikum, everyone. I hope you all can see my screen. So I am a rheumatologist in McKinney. Little bit on rheumatology. So it is the field of medicine in which we diagnose and manage joint diseases. After doing an internal medicine residency for 3 years, we spend another 2 years in specialization in this field, after which we do our ABIM board exams. And after that, we get certified to practice rheumatology. So just a little background. As Dr. Zahabi went over, this talk is part of the AMWPA lecture series. This was a non-profit organization founded in 2008, and its emphasis is on promotion of education of women and preventive medicine. Here's the website address. For more information, please do visit their website, amwpa.org. And this lecture will be available on YouTube for review later, if any of you want to review this. So very notable activities, even during the pandemic, AMWPA did provide masks to the community and meals to the frontline workers, along with organizing health fairs. They provide free flu vaccines. And I think very notable is this community education through organization of lectures. So great work being done on that end. I also want to recite a surah from Al-Isra, Bismillah ar-Rahman ar-Rahim. وَنُنَزِّلُ مِنَ الْقُرْآنِ مَا هُوَ شَفِيعٌ وَرَحْمَةٌ لِلْمُؤْمِنِينَ. And we have sent down in the Quran such things that have healing and mercy for the believers. So indeed, as we embark on the journey of healing our bodies, we know the ultimate spiritual and healing of our bodies through the recitation of the Holy Quran. So today, it's beyond the scope of a 1-hour lecture to cover arthritis.
Sana, do you want to share your screen, please?
Oh, so it's, okay. Let me do that. Okay, I'll have to.
There is a button, the green button at the bottom.
Okay, let me just do that. Okay. I thought my screen was on, but let me just try to load it again. Yeah, no, this one.
Perfect.
Okay. Are you able to see it?
Yes. Thank you, Dr.
No problem. So today in this brief hour that we have, we're going to really simplify arthritis, understand really what this term means. What is the burden of arthritis in the community? Going over some of the importance of the early diagnosis of arthritis. What are some of the key symptoms which patients can understand, and they can start differentiating the type of arthritis they have, when they should seek medical care, and what are some of the treatment options available. So arthritis really refers to joint pain or joint disease, and this is not a single disease entity. So it is important to understand that there are about 100 different types of arthritis and related conditions. They can involve joints, surrounding muscles, the tendons, ligaments, which are structures that provide support to the joint, and bursa in the surrounding joint. These are soft tissue pockets around the joints. People of all ages can get arthritis. People of all races can get it, and both genders, male and female, can get affected with arthritis. However, we do understand it's most common in women. We also understand that certain subsets of arthritis can affect the pediatric population because it's classically thought of a disease of old age, but we have to recognize that some young children can also deal with arthritis. So the burden in the community, so in the adult US population, about 91 million people live with arthritis or joint disease, out of which 54 million adults have a doctor-diagnosed arthritis. So you do see this gap in which patients are not being diagnosed. We know its prevalence increases with age, and after age 65, 70% of women are at risk of getting arthritis. So this is a really simplified classification. We know arthritis involves more than 100 disease types, but to really simply understand it, we can simplify it by classifying them into two broad categories. The most common one is osteoarthritis, which is also known as degenerative joint disease. It will usually occur after age 50, mostly affecting your weight-bearing joints, such as the hip joint, knee joint. It can affect some parts of the hand as well. Spine is another area, the neck, the lower back, and it's usually a very slow progressive disease. The other category that we deal with is autoimmune arthritis, which is less common, however, very important to recognize. Some of the diseases that are included in this category is rheumatoid arthritis, psoriatic arthritis, lupus, and connective tissue diseases, and ankylosing spondylitis. Some of you may have heard of these conditions. This type of arthritis can occur in the younger age group. It is classically associated with inflammation, so it's sometimes also referred to as inflammatory arthritis. This arthritis can be rapidly deforming, hence it is essential to recognize it early and get an early referral to a specialist or rheumatologist for management. So osteoarthritis, as stated, about 27 million adults are affected with it, whereas rheumatoid arthritis is around 2 million people. Ankylosing spondylitis affects about 1.5 million people in the adult population, whereas 0.1% of the population has lupus. So definitely osteoarthritis is most prevalent. So when patients have joint pain and they go see their primary care doctor, so 1 in every 5 doctor visits overall are associated for joint pain, most commonly being osteoarthritis pain, back pain, or knee pain. Another feature that patients deal with and physicians see is their work limitation or activity limitation caused by their joint pain. So patients come in for medical leave from work or FMLA paperwork. Around 23 million adults have an activity limitation, which definitely affects our workforce. It causes loss of productivity. Arthritis is the leading cause of chronic disability, and it is the second leading cause of acute disability after respiratory illness. It also causes significant financial burden on the community. So it's the leading cause of Social Security disability payments. End-stage arthritis is treated with surgeries. So 10% of all surgical procedures being performed in the US are related to joint disease. And the direct cost of medical expenses and indirect costs related to missed work and productivity counts to about 5.7% of the GDP. So it's important to realize all this burden because we want to definitely get in, diagnose these patients early, manage them well so that we reduce the cost which comes with end-stage disease. When as physicians, we see our patients with arthritis, and this will also hold true for family members who are living with patients with arthritis. It's important to treat these patients with compassion because it's a very challenging condition to live with. They are often not diagnosed for years. So this is a quote from a patient with arthritis. It says, "When you're frustrated with me because of the things I cannot do, just think how frustrated I must be because I'm not able to." So as a patient, when should you go in and see a doctor for joint pain or arthritis? So if your joint pain is persistent, if your symptoms are lasting more than 6 weeks, if you're experiencing limitation in your range of motion of any particular joint, you've lost your range of motion, if your joint pain is requiring daily over-the-counter medications for several days, you definitely should seek help. Also, there are certain urgent symptoms with joint pain, which are indicative of inflammation in the joints for which you need to go in and seek medical care, which includes swelling or fluid in the joints. There is heat, redness, or warmth. There's your stiffness in the joints in the morning is lasting more than 30 minutes. So you're really feeling stiff when you wake up. Or you have other associated symptoms that may indicate that you're not well or you're sick, like getting a fever, getting a rash, getting some eye dryness or eye redness, and you've experienced weight loss for no reason. So all of these should make you seek medical care. So going over some brief symptoms of the degenerative arthritis or osteoarthritis, and these are some simple symptoms that if patients recognize this, they can start to figure out, what may be causing their joint pain. These patients usually have pain present towards the end of the day. So a patient may say, "Oh, when I come home from work, my back is hurting or my hip or knee is hurting." When they wake up in the morning, they will have stiffness, but it classically will last less than 30 minutes. Pain is usually worse after activity or walking, and it's relieved by rest. And as we stated, the base of the thumbs in the hands, the knee, hip, or lower back can be affected. They usually don't have any other classic signs of illness, like they're not otherwise sick. They're generally well. They won't have a fever or a rash or weight loss. Coming on to autoimmune arthritis, there's some hallmark features of this type of arthritis that include signs of inflammation. So if any part of your body is inflamed, you get these features, and that holds true for joints as well. There will be heat, there will be redness, there will be pain, there will be swelling in your joint, and they will also experience loss of function. These patients also have stiffness in the morning, but it lasts much longer than osteoarthritis. Some patients come up to us and say, "Oh, I'm stiff for about 1 to 2 hours. I cannot get up and go to work because I just feel so stiff in the mornings." Their pain, interestingly, improves with activity. So after the first 2 hours, once they get moving, going to work, they actually feel better. They will have some constitutional symptoms, and those are symptoms of just general illness, such as fever, fatigue. Some of them may have sun sensitivity, some sores in their mouth that may be indicative of certain type of autoimmune arthritis. When their doctor does their blood work, they will have elevated markers for inflammation, which is SED rate and CRP, and there's certain other specific labs that can be ordered for specific diseases, such as an RF, CCP, or ANA. So when you go into the physician, what you will experience is a very detailed history. You will have a physical exam, and most specialists will do a joint count. So they will actually document the number of joints that are swollen, the number of joints that are tender. It's interesting because that helps the physician make a diagnosis of your condition. They will order some basic labs. So it's a simple blood draw in which they're checking your inflammation markers, some antibody markers, and some plain x-rays of your area affected, mostly the hand, foot, hip, and knee. If you have a specific swollen joint where there's fluid, which can be present on examination, then there is a procedure called joint aspiration that your physician may recommend. I know patients get a little apprehensive regarding this procedure, and it is actually a very safe bedside procedure, and it offers valuable information. I want to make sure that my camera is turned on. So let me just make sure. Yeah. Turned off. So let's see here. So hopefully it's now working.
Yes, it's working.
Okay. So, so it's a safe procedure. It's done at the bedside, no general anesthesia to be done. So, and it will give very helpful information because the fluid that is aspirated from the joint can then be tested for inflammatory cells. It can be tested for infection. It can be tested for gout. So, and it's done with just little numbing spray over the area, and the needle can pull the fluid. So it's a very helpful test. So as I said, a logical method in which your physician goes over your history, examines some basic labs really gives us a good idea as to what may be going on. Patients usually don't need a very extensive testing when, so you need to use the appropriate tests to diagnose arthritis. So let's do a little case review and we'll go over this case. And I think physicians and patients will start to think about what type of arthritis may be going on here. So this is a 66-year-old female. She's presenting with 1-year history of joint pain, and she points to the base of her thumbs and both knees. She states that the pain gets worse with activity and is relieved with rest. Morning stiffness is lasting around 20 minutes, and she has knee pain when climbing up the stairs with a grinding sensation. She's denying fever and weight loss. So what do we think? What type of arthritis is she dealing with? I think there's some key giveaways in the history, which are very helpful. First of all, the age of the patient. So we do see she's a little bit older age group. She has pain in the weight-bearing joint, which is the knee. Pain is getting worse with activity. Morning stiffness is lasting short duration, only 20 minutes, and no other symptoms. So we are already on the right path, thinking this is possibly osteoarthritis or degenerative arthritis. You look at her and examine her hands. When we did that for this patient, there was bony swelling, base of the thumbs, and in her distal finger joints. And then when we did her knee x-rays, we saw loss of joint space in this inner aspect of the knee, which is called the medial compartment, whereas the lateral or the outer part of the knee was still preserved. And this is the area which bears the most weight. So there is joint space loss. And we pretty much made the diagnosis of osteoarthritis with history and physical exam and x-rays. So as stated, osteoarthritis is the most common, and most of this we've already gone through. It's a degenerative process. I think the key here is to realize the process is wearing out of the cartilage or the cushion in the joints. It is easily diagnosed with the initial testing. It's usually managed medically with surgery as last resort. So some of the risk factors for osteoarthritis that we all want to be aware of, as most of us are prone to getting this later in life. So age, the incidence does increase after age 50. There is a genetic component. So if it runs in your family history, you will be at risk. So obesity is a modifiable risk factor. So obesity affects the weight-bearing joints, the hip, the knee, the lower back, but interestingly also can affect things like the hands with osteoarthritis. History of previous trauma will place you at risk, smoking, and overuse activities such as certain sports and high impact injuries, and can be seen in dancers and boxers. So just this talks about pathogenesis, which I don't think we have to dive into too deep, but it's really, again, emphasis on the wearing out of the cartilage. So repetitive trauma to the hyaline cartilage in the joints that leads to degradation of the cartilage and results in bone remodeling that will cause spur formation and local inflammation. So here's a diagram. So this is a normal knee joint, and you see this smooth, glistening joint capsule. And then we see this really nice, smooth hyaline cartilage between the joint, blue here in color. And this provides as a shock absorber for the knee. And in the osteoarthritis, you see it's really torn away, it's degraded, and you're really having your bone rubbing on bone. So really your shock absorber is gone, and you're really getting that pain because of there's nothing there to reduce the friction. So that's the process of osteoarthritis and can be associated with this local inflammation in the bone. So here's an interesting clinical question. So this is a 72-year-old grandmother who has established osteoarthritis, and you go to visit her, and then she tells you that she can actually predict weather changes because her joints tend to hurt more. So is that true? So it's interesting that patients with osteoarthritis they can have a heightened pain response with the barometric pressure change. And so it's not really related to the warm climate or cold climate, but it's really the changes in that barometric pressure. So they will actually feel those changes and have a heightened pain response, tend to hurt more. We see these flares of pain in our clinic with the weather changes. So how do we manage these patients? So most important is conservative management. So patient education is very essential, knowing their risk factors, being aware of it. Weight loss is a cornerstone of therapy. So every 1 pound of weight that the patient loses, there is about a 4-fold reduction in joint load. So we actually tell them to have small targets. If you tell them from the beginning, you have to lose a huge amount of weight, that's very discouraging. So I actually tell them if you lose the first 5 pounds or 10 pounds, and they actually get adequate relief of their pain. So we encourage them for every small step is very helpful. Physical therapy is a very important part. It will help strengthen their muscles. And then we do, talk about assisted devices, canes, walkers, braces for the knee that provide additional support. Paraffin bath for the hands will reduce stiffness. So role of exercise is, we cannot state enough, because this is really going to help maintain their joint function. It will help reduce pain and strengthen the muscles around the joints. It's going to prevent further deterioration. The type of exercise program we recommend for these patients is one that will minimize weight bearing and increase the range of motion. So some of the exercises to do is swimming is great, cycling, which is stationary bike, elliptical are all good options. Water therapy is great. Some of them can just get into the water and walk in water in the pool, and that's very helpful. So in terms of medications, there's a lot of research. However, no medication so far has shown to stop or reverse the disease process. They can alleviate symptoms. So some of the over-the-counter medicines, Tylenol, you've got to be careful about the dose. You can take up to 650 milligram every 8 hours. There are anti-inflammatories that are available. You all have heard of Advil, Aleve, ibuprofen. Make sure you use the lowest dose and do intermittent dosing, as they can cause stomach irritation, stomach bleed, and kidney irritation. So if you're using them a lot, please get in touch with your physician for directions. And some other over-the-counter options are topical creams like lidocaine, capsaicin, Voltaren gel. Some supplements available such as glucosamine and chondroitin. They are not FDA approved or regulated, but they are safe. They have no side effects. So we tell our patients try them for 2 months at a time. If they reduce pain, that's great. They can stay on it. Otherwise, we ask them to discontinue it. So prescription medications are your anti-inflammatory that are prescribed, such as Celebrex, meloxicam, that are less irritating on the stomach. Pain medications have a role, like tramadol. And now the neuropathy medicine, Cymbalta, which is an SSRI, is now FDA approved for osteoarthritis pain. Corticosteroid and joint injections are helpful. If it's a particular joint, like a knee or an ankle that has osteo, we can inject the joint every 4 months. We don't want to do it more frequent than that, because there's risk of infection with every injection. That can really be helpful. And gel injections, which is viscosupplementation. This is the injection of exogenous hyaluronic acid into the knee joint to act as a lubricant and reduce friction. So those are the 2 injection options available for knee osteoarthritis. But all of this is under the guidance of your physician. So surgery is really indicated for last stage. So we should definitely not be the first option that you have osteo and you need surgery. That's not the right approach. So if you've tried your medical therapy, you've tried your injections, and you still are having pain that is waking you up at night, or you cannot walk more than a block, cannot climb stairs, then that is an indication for knee replacement or hip replacement surgery. And then you definitely want to find an experienced surgeon who's going to understand your disease, get you into therapy before and after surgery for good results. So that's going to be important. Some new therapies are under investigation a lot. Some of them are really talked about, getting very popular, are the platelet-rich plasma injections, and then the mesenchymal stem cell injections. So these, again, are not FDA approved. So, your insurance is not going to cover them. They can be quite costly. We need more data to look at the efficacy. But the main theory is that these platelets or the stem cells increase your growth factors, increase cartilage cells in the joint, and regenerate some of that cartilage. That's what the thought is. So it's overall a slow progressive disease. Patients can be asymptomatic for years before they start developing increased pain. And once they get pain, it can be it can progress quickly, and it can lead to severe limitation in function and then disability. So you definitely want a physician who's going to understand your disease and not dismiss these patients as having, oh, you just have degeneration. You definitely want to have a plan for your patients and really understand their disease. So let's switch gears a little bit. Let's go on to another case where we can start thinking as to what may be going on. So this patient is a 32-year-old female who's coming to our clinic with a 3-month history of pain in her fingers, knuckles, and wrists. Her stiffness is lasting a little longer, 45 minutes. She's also saying that she's noticed some weight loss without any reason of 15 pounds and fatigue. On exam, she has pain in her wrists. Her temperature is 100.6, so she has a low-grade fever. So is she dealing with osteoarthritis or an autoimmune arthritis? So again, I think here there are some giveaways. She's a younger age group. She has chronic symptoms lasting more than 6 weeks, and then she's having increased morning stiffness with some other signs of inflammation are present on her history. So we do think this may be an autoimmune arthritis. This is a patient we want to quickly work up and get in also with the specialist. So when we did this patient's labs, she had high inflammation markers such as an ESR. She had a positive rheumatoid test, which is the rheumatoid factor. She also had anemia. Her hemoglobin was 10.2. That can be a marker of inflammation. And the CCP antibody, which is a specific marker for rheumatoid arthritis, was also elevated. So we made the diagnosis of rheumatoid arthritis. Her x-rays had shown thinning out of the bones around the joints, which is called osteopenia, and she had significant joint space loss and punched out areas which are called erosions in these knuckle areas. So this was rheumatoid arthritis. This is our chronic autoimmune arthritis. This can have an earlier age of onset, usually can start in your 40s up to the 60s. Women are 3 times more affected than men. It's interesting that this arthritis affects small joints of the wrists and the fingers and the feet. And a subset of this type of arthritis is seen in children. It was called juvenile RA, now it's called juvenile inflammatory arthritis, and we can see it in young children as well. These patients will have other symptoms of illness and inflammation, such as fatigue, weight loss, and fever. And this really causes deforming arthritis pretty quickly if not treated. It can lead to permanent disability in a much younger age group. Thus, timely diagnosis and treatment is imperative in these patients. Going on to another type of autoimmune arthritis is lupus arthritis. So we know lupus as a condition is more common in women, can affect much younger age group. They will have other signs of lupus, such as a rash. This patient has a faint butterfly rash present over the cheek and the bridge of the nose. They can have oral ulcers and joint swelling. Again, they can get deforming type of arthritis. Their labs will reveal positive tests for lupus, which are simple antibody markers, and they again require early treatment. So this is really some of the end stage cases of rheumatoid arthritis. If not treated, you can really look at the fixed deformities that can occur in the fingers, inability to close the fist, rupture of the tendons, and again, at advanced stage where you can get dislocation of these metacarpal joints and a lot of significant deformity. Let's go on to another small case and we'll see if we can get to the diagnosis based on history and exam. So this is a 44-year-old, so again, a young male patient who's coming in with some ankle pain and swelling. It's going on for 2 months, so for a while, persistent. He also complains of low back pain with stiffness lasting 50 minutes. So again, significant stiffness. When we examine him, we notice that he does have fluid and a swelling in his left ankle, and that his right fourth finger appears pretty swollen. The entire digit is swollen. So we do start suspecting that this may be an autoimmune arthritis. And so we do a more detailed exam. So we go back and look at his skin and his nails. And there we see that he has the pitting of the nails. And we see this plaque lesion at the back of his neck, which is consistent with plaque psoriasis. So the diagnosis is psoriatic arthritis, another type of autoimmune arthritis. So this can occur in about 30% of patients with skin psoriasis. The arthritis may sometimes precede skin disease. Affected joints are the hands, feet, and the spine. They can get nail changes with actually loss of the nail or pitting. There is a subset called arthritis mutilans, which is a very destructive type of arthritis. And it can also involve your axial-like spine and the part where the spine meets the hip bones, the sacroiliac joints. So this is actually a picture of arthritis mutilans seen with psoriatic arthritis, complete loss of the joints and the digits and telescopic of the fingers, very destructive. So let's talk about management of autoimmune arthritis. So we really want to manage the inflammation. So glucocorticoids or steroids are used initially to control inflammation quickly, but you know that they're associated with side effects. So then we introduce the disease-modifying therapy, and we have a couple of options there. You all may have heard of methotrexate, plaquenil, sulfasalazine. We always use a stepwise approach, starting with our oral disease-modifying therapy, but now we have options of biologics, which have really changed the landscape of treating these diseases. And we're going to talk a little bit more about them. These come in the form of injections, and they target specific markers of inflammation. All of these therapies have to be given with precautions. They will lower the immune system, so they are immune suppressing. Our biggest concern is risk for infection when patients are on these therapies, any liver or kidney toxicity. So once you're on any of these therapies, you will require routine physical exam and monitoring, lab monitoring by a physician about every 3 to 4 months. So biologics are really interesting. They're engineered versions of natural molecules called monoclonal antibodies. And now you all may have heard of a friend or someone of your colleagues who's on this therapy. They can target specific markers such as the anti-tumor necrosis factor therapy is Humira and Enbrel. And then you have the other specific cytokine therapy. There's anakinra, Actemra, Cosentyx, Skyrizi, and Benlysta. Benlysta is now approved to treat lupus. So as much as, the concern is out there with biologics that they are too strong or they will immune suppress, most of them are actually pretty safe to use as long as it's done under physician guidance with some routine labs to monitor their efficacy and for side effects. So these injections can be pretty expensive. So you want to use them appropriately after the diagnosis has been established, after patients have failed their first-line therapy. And you have to be careful and look at the financial situation. There's a lot of assistance programs available with these medications that can help patients. So again, along with managing the autoimmune arthritis, we also treat the patient as a whole. So we're not only looking at joints, we treat their comorbid conditions. We talk about them about their obesity, about their cardiovascular health, about their high cholesterol, about tobacco use, as all of these can continue to trigger inflammation. These patients are living with arthritis, so they can be anxious about it, they can be depressed. So we do a screen for depression. We also do an osteoporosis screen for bone health. We talk to them about their weight management. Sleep regulation is important as it will reduce pain if they're sleeping well. And then we talk about diet, which is very physician directed. I personally talk to them about an anti-inflammatory diet in which I recommend the Mediterranean diet. And that also results in weight loss. So to review what we have talked about today is, it's important to understand the burden of joint disease in the community, as it is the leading cause of chronic disability, and how we can get in earlier and treat these patients earlier so that we can reduce the expenses, medical expenses. Patients should seek medical care if their joint pain is lasting more than 6 weeks. Osteoarthritis, which is the most common arthritis, affects patients later in their life. It is primarily managed with physical therapy and exercise. Other options are anti-inflammatory medications and pain medications, which are given with monitoring. We encourage patients about weight reduction, and then we do consider surgery if they've failed all of these management options. Autoimmune arthritis, which includes conditions such as rheumatoid arthritis and lupus, does affect the younger age group. You have to keep in mind that this is a rapidly deforming arthritis. Within the first 2 to 3 months, patients can get permanent joint damage. And early recognition and referral to the specialist is important. And many options are now available to treat these patients, ranging from oral disease-modifying therapy to the subcutaneous biologics. And most of them are safe to use with precautions. So our goal when managing osteo or autoimmune is to preserve the joint space for the patient so we can prevent disability. So thank you. This wraps up. And here is a physician telling the patient that his cholesterol, weight, and self-importance are too high, which I think, my take is that I think it's important. It's good to have some self-importance, because then you make sure you go in and you get seen and you manage your health well. So I don't think that's a bad thing. And again, to review, this is the website address for more information, amwpa.org, and the YouTube address. And this lecture will be available later for review. So thank you very much. And we will now open it up for any questions.
Thank you, Dr. Makhdumi. That was an excellent presentation, and you covered a lot of material in this. A couple of things before we open it to the general audience, that it occurs in younger people as well, and we should not, we should make sure that they have access to doctors, but also that in younger people, the autoimmune diseases can also be life-threatening, as well as bring about a lot of disability. And today is the best of times, because we have the ability to actually treat it aggressively, and also to, in a sense, bring about a cure, if you will. Anybody have questions? I don't see anything in the chat, but if you want to open up your phones, preferably, I would prefer everybody write on the chat so that I can read it aloud and we can discuss it.
Sure.
Any takers? No? You were just completely lucid, Dr. Makhdumi. It made sense.
I hope. Well, that's the hope. And just to speak to your point, absolutely. So this younger population, we know juvenile arthritis, it can actually have a systemic presentation where the kids can be so sick, right? They can have anemia, thrombocytopenia, and then many times are admitted to the hospital. So for as parents, being able to recognize that this could be an autoimmune arthritis is important. Yeah, because, and Dr. Zahabi, you probably see in your practice, I mean, patients are many times just dismissed by other, places that, or you just have pain, or this is just wear and tear, and they never get the right workup. So it is important.
It is also important that we see these patients early. And at that time, a good rheumatologist, a good doctor is able to pick up so early before there are any X-ray changes, before there are any blood tests. And we really want to start treatment at that time. And we can actually change the course of the disease, which is incredibly important. And we're living in an unbelievable time as far as treatment of these very, very destructive diseases are concerned.
Absolutely, absolutely.
So I have a couple of questions here. What do you suspect Ehlers-Danlos syndrome in patients, as there's a marginal difference between Ehlers-Danlos syndrome and fibromyalgia? If you want to talk about that.
Yes.
How often do you see it, and do they get misdiagnosed as having fibromyalgia? What are the ramifications over the long haul in missing or not adequately educating patients on Ehlers-Danlos syndrome, which is also called hyperflexibility syndrome?
Absolutely. So very good question. So, fibromyalgia, just to put that first to the aside, it can be seen in any of your joint pain patients with arthritis. Fibromyalgia is that exacerbated pain. So for sure, if we can see it in osteoarthritis and rheumatoid arthritis, we can see them in patients with Ehlers-Danlos. So Ehlers-Danlos patients really have a collagen, it's a genetic collagen tissue disorder. So that's the way their collagen, or the tissue in the joints, the way it's structured, is really lax and loose. So it's not an autoimmune arthritis, it's not an inflammatory arthritis, it's a genetic arthritis. And I want to see if Dr. Zora Shah is still on our group with us, because she's a geneticist. And so we actually have to refer our patients to a geneticist for the diagnosis of Ehlers-Danlos syndrome. Coming to us, we see patients because patients with a hypermobility aspect of Ehlers-Danlos syndrome are prone to getting the degenerative arthritis earlier. So we see patients with Ehlers-Danlos in a younger age group are developing osteoarthritis because their joints are going through more range of motion, and that's where I step in and treat their osteo. But there is no cure for the Ehlers-Danlos, but they want to get their genetic testing and counseling done for their family. And
I'm here, Sana.
Okay, hi Zora.
Hi, and that was my question.
Appreciate Zora kind of really taking in our patients and going through the whole genetic counseling. It's been so helpful to have that team with us. So Zora, if you have anything to add.
Yeah, sure. So first of all, I need to add that there's almost 17 type of EDS has been diagnosed to date. It's not only EDS hypermobility type. And most of the EDS have genetic etiology, whereas EDS type 3, also called the hypermobility type, we make diagnosis based on the clinical findings, such as, Biotin score more than 5 in adult patient, or if it is, kind of pediatric patient, then we usually give 6 score or more. But the other type, like such as classical type or EDS type or myopathic type, they all have genetic etiology. So it's very important to evaluate these patients by a certified geneticist so that exact diagnosis can be made. And one of your patients, Dr. Sana MAKHDUMI, this patient has a very rare type of EDS called the myopathic type, and the recommendation is to avoid extreme heat and excessive exercise because their CPK may be higher and they require hospitalization for IVF, hydration. So, it's important to make exact diagnosis for the management plan.
Very good. Thank you, Dr. Zora. A couple of other questions that are very important, I think, to the lay public, and that is how do drugs like Cymbalta work? But also, what about the joint juice curing arthritis, supplemental vitamins? You mentioned briefly, you alluded to a Mediterranean diet. Talk to us a little bit about turmeric oils, fatty oils, and where do you stand on that?
Sure. So, so I really wish, it's like my hope that they will actually do controlled trials on these supplements. I think food and these supplements have benefit, so it's my personal opinion, because, we speak from medical evidence as physicians. So there's just, I think, they don't put enough money on doing trials on these supplements. But from whatever small case studies, anecdotal data we have, turmeric has anti-inflammatory properties. Glucosamine and chondroitin sulfate have been shown in small studies to reduce pain. And the other aspect is these supplements are safe. So, I don't discourage my patients. I encourage them, if they want to try it, but I don't ask them to invest too much money and go for any specific brand. Again, we can't talk about that since they're not regulated, but something that is affordable. I'll give them a time period, try it for 3 months and see how your symptoms feel. If it helps them, for sure, I will recommend them to be on it. Talking about the joint juice, I mentioned that those are the gel injections. That is the exogenous. So in the lab, they've manufactured kind of that joint fluid, the hyaluronic acid fluid, and that can be injected into the knee. It gives a cushioning benefit. Benefit may last. Our hope is when we're giving an injection is the benefit should last for 3 months, because you don't want to inject earlier than that. If they're getting that benefit, that can be their means of management, and that definitely has a role in managing their arthritis.
And it'll certainly save some time before they go on for surgery.
For sure.
Talk to us a little bit about Cymbalta, because there was a question on Cymbalta and SSRIs. How do they work? And I think it's controversial, but it also does help with pain. So your experience with it?
Yes, so Cymbalta, as we all know, came out in the antidepressant line. So it actually blocks reuptake of serotonin and norepinephrine. So it's really blocking your neurotransmitter uptake that increases your endogenous serotonin and norepinephrine. So your body is kind of alleviating pain by increased neurotransmitters, because it's inhibiting the blockage. So it has shown role in joint pain reduction, nerve pain reduction. It's used for post-herpes neuropathic pain. So, but in my experience, it's variable. It depends on, because everybody's pain is not the same. Some actually have a nerve impingement with their joint arthritis. So they will get significant relief. I'll put them in low dose, 30 milligram of Cymbalta, and they come back and they're like, we feel so much better. Whereas another patient may not get the same relief. So it is a bit of a trial and seeing how they do, depending on what their mechanism is, the predominant mechanism of their pain. But it has a role.
Yes, thank you. There's a very good question. How soon do you recommend testing in an asymptomatic patient, I assume, for lupus if there's a family history? Which brings us to a very important question, that if there's a family history, do you encourage the other family members to get tested? Do you advise them? Is there anything that is preventative or prophylactic?
Yes. So education. So family members need to be educated about the signs and symptoms of lupus. And if they're living with a family member, they're probably aware it's going to be a rash or oral ulcers or joint pain. I do not recommend testing unless someone has symptoms, because then you're really chasing blood work and a lab, and you're not going to treat lab or blood work. So if you're a family member of a lupus patient, you need to be aware of the signs. You need to just have a routine annual physical workup by your primary care. That will include a good physical exam and routine labs. And that should be about it, and not getting too anxious about it, because again, lupus risk is 0.1% in the community. And, so your risk is not that high. It is slightly high if you have a family member, but no, I do not recommend testing for asymptomatic patients.
And I tend to agree with you. There is another question, which I think is also interesting, which talks about degenerative or wear and tear. If someone has spurs on x-rays with foot pain, is there a best way to manage it?
Well, so I'll give my take and then Dr. Zahabi can give hers. So a lot of people will have spurs, so if you x-ray people maybe after age 35 or 40, unfortunately, we will get, because, that's how the body is, and it will start with wear and tear, some spur in the heel area. But if it's causing pain and if it's really symptomatic, then, I again start with like a heel pad or a heel cushion in the shoe, and some stretching exercises, strengthening, topical solutions. I usually won't recommend surgery, because usually it will not cause that amount of pain. So spurs are pretty common on x-ray, and you got to make sure that the spur causing your symptoms and not something else, because spur should not cause that much pain.
Right. I tend to agree with you. And it is, we want to really use non-medical devices, changes in footwear, which will help cushion the heel. And that's important. Although spurs in some people may be a first sign of psoriatic arthritis and enthesopathy. But yes, I tend to concur with most of your recommendations. I think that's about it. Anybody else who wants to pick at Dr. Makhdumi's brain tonight? It's a Sunday night. Excellent. Thank you, Dr. Makhdumi. Thank you for spending so much time with us. We truly appreciate your input, your advice, and your participation in AMWPA. We welcome you in the community and wish you lots of luck and lots of more presentations to follow. Thank you all very much. Thank you for joining us this evening. It is a Sunday evening, so we truly appreciate everybody who's there. Thank you all, and good night.
Thank you very much. Thank you, Dr. Zahabi, for moderating, and thank you everyone for your participation. Have a great week. Thank you.
Bye. Allah Hafiz.